We have seen the number of cases really increasing over time. So before 2018, we used it very infrequently. But you see that now in 2021, we had almost 100 cases in 1 year. So it's really an expanding field. And the reason is that the number of indications has increased, and they are increasingly used not only for the in-label indications, but also for off-label indications, which now account for approximately 50% of the cases here at our hospital. If you look at the outcome results of this study, you see that technical success rate and clinical success rate was not really different between these two cohorts. So it seems that we can have clinical success quite easily, even if you're not very well trained in lumen-opposing metal stents. But if we look at adverse events, there was a clear drop, and this I think is a clinically relevant drop. So the number of complications halved over time. And so we looked at the different cohorts, and in fact it was across all the indications that we saw that the complications were going down. And this is the major theme of this presentation. Yeah. Yep. Okay.
So I think you can also deploy it without any fluid contents.
Yeah. Okay, so this is another situation where we had to measure first the distance, so it was also quite far away, the collection. I'll play the video. And so we had also a pre-procedure CT scan, so there was no aneurysm. We always use Doppler to ensure that we are not puncturing large blood vessels. But here you will see that we experienced an immediate adverse event.
Oh.
So it was exactly the same, but here you have the endoscopic marker that was clearly inside. So we were sure that we could now safely deploy the last flange of the stents. But then you will see what happens. Immediately there is blood coming. So this is something that we were very worried about. So you will see that fortunately there was also pus draining. So we were sure that we were in the collection and not somewhere else. But yeah, how would you manage this? It's an infrequent situation.
It's a very difficult question.
Anyone who has seen this before?
No.
Not immediately, but like the night when the stent was placed, patients started massive hematemesis, so we were quite sure it was a vessel in the wall that started bleeding. Very often these necrotic things have very big vessels in the wall, and if you hit them or stent is eroding through them, you get massive bleeding, and most of the time we call interventional radiologists to solve this, because this you cannot solve endoscopically, I think.
No, well, here in this case, it was also, it must have been a large blood vessel in the wall of the stomach. We did local tamponade with an extraction balloon. It stopped, fortunately, but the best thing to do is immediately call also your interventional radiologist. Say, okay, look, I'm having this problem. Please be my backup if the patient is not doing well, because bleedings can be very severe and.
Can I ask you a question? There is no ABM, no evidence-based way to manage that. So really here we are for discussion, but I never experienced that, but I would choose more dilation balloon to make the compression. I see that you choose an extraction balloon. Why?
Because I saw at a certain point you see where it comes from. You see the pulsating vessel.
Yes.
So it starts bleeding here, and then at a certain point we saw that it was really coming from the edge of the stents, and so it was good enough for local compression with the balloon, because otherwise you have to go in And I don't think that it would have been easy to really go into the lumen again. So here's the pus. You see the pus.
I had once a bleeding after extraction of the
there you see the
stent.
pulsating vessel. Yeah.
I had it once after extracting the hot access stent. Immediately there was like a vessel on the border, and then I could locally treat it like an ulcer bleeding effect with clipping.
So where we do, for example, a gastrojejunectomy LAMS together with a choledochoduodenostomy, and I think the results are worse than with hepaticogastrostomy and gastrojejunectomy.
I'm happy to hear that from you, because I was wondering, looking into the guidelines from the ESGE, they recommend for distal obstruction, for the easiness of the procedure, the choledocobulbostomy instead of the hepaticogastrostomy. So this is in the recommendation based on several papers, but they admit it's a low quality evidence. But I'm happy to hear you about that, because that was when I presenting a talk, I would say 5 years ago. The data that I was looking to were in favor of doing EGS instead of choledochoduodenostomy because of better results. But currently we have to admit that the guidelines are in favor of doing choledocobulbostomy.
Indeed.
What kind of stent would you place, or in rare case of ingrowth, would you place a new axis?
It depends. You can place a new axios if you still find a space, because the bile duct will be dilated again, of course. If we still have access through the original lumen,
for the stent in stent,
then we go for stent in stent with a covered SAMS.
We discussed that we didn't, we haven't used it yet. I didn't know if you use it in Brussels.
Yeah, we had access to a few of those balloons, so we have used it in a study.
Yeah, because they're not available.
They're not available,
commercially available in Europe.
No. Yes.
And Maridi, do you have a personal advice about the benefit of it?
It makes the procedure a little easier, because you really can do the location from where you want to put your stent, and just in between those two you fill water, and you because you have the two balloons, you really you see very well where you will place your stent, and you have to give lots less water, of course. It goes a little bit faster, because sometimes when water is really floating and passing very fast, it might be a little bit more tricky.